All right, we go.
Good afternoon, everyone. Welcome to Health Talks, a webinar series presented to you by SJCS Alumni Association in collaboration with St. Jude Catholic School and the SJCS Parents Auxiliary Group. 大家好，欢迎大家连线参加今天的健康讲座网络研讨会。Health Talks is a series of webinars initiated by the SJCS Alumni Association to enlighten us with topics on health and wellness. 健康讲座是崇德校友会举办的网络研讨会系列。To begin today's session entitled COVID-19 Vaccines Cha-Cha-Cha, Should Children Be Vaccinated? Let's call on our school principal, Father Paulino Belamide, to lead the opening prayer and give his short message.
Father King, you're on mute.
So good afternoon, everybody. So let us put ourselves in the presence of God.
Good afternoon.
In the name of the Father, and of the Son, and of the Holy Spirit. Amen.
Amen.
God, our Father in heaven, we praise and thank you for this day and for your manifold blessings. We are faced with a question whether we should vaccinate our children. Lord, bless this webinar, our speaker, Dr. Ong-Lim, all the participants. Feed our minds with the knowledge that we need to have. Give us the wisdom and courage to do what should be done. And increase our faith that we may face challenges and uncertainties with strength and confidence, and see with our heart your ever-present guiding hand. We ask this of you through the intercession of the Blessed Virgin Mary, the mother of your Son, who lives and reigns with you and the Holy Spirit forever and ever. Amen.
Amen.
And St. Jude Thaddeus,
Pray for us.
Well, I thought magdadasal lang ako, may message pa pala. Anyway, welcome to all of you, and of course, we thank the SJCS Alumni Associations for arranging this webinar.
Recording in progress.
Pangilan na to, Johnny? We have been doing this for a series already, different series, no?
Yeah, several series na po, kasama
Anyway,
ng Queen Talks.
Yes. So it's well appreciated. And especially now that we are thinking, the school is thinking of piloting face-to-face classes in some form, maybe next year or in the next school year. The issue of vaccination is very important. Of course, with the 18 and above, probably that's easier to handle this issue. But the younger ones, I think, that's another issue. And I think this webinar is very timely as we begin to think of the possibilities. Regarding this transitioning to the new normal, as the DepEd puts it, is of course a big concern for our parents, no? And I can get the sense that, of course, the school is kind of pressured to not really pressured, but to see how the other schools are going to do it. Personally, I think we should not hurry this thing, and the parents agree. The sentiment that we should not just because people are doing it outside that we should do it. No, we have to carefully weigh the the pros and cons of this matter. And well, in the case of DepEd, I think the main concern is that they are not learning as they should in the face-to-face, in the online setup. So there's a big concern about baka walang natututuhan yung mga bata, o kung meron man, konti, hindi yung dapat. Sa St. Jude, it is not that much of a concern, I think, because we're kind of confident that we are doing quite well in the online learning. But still, everybody admits that it's not the best situation to learn. And so our concern really is whether mentally, if we have another year of online learning, whether that would be, good. Yeah, we are concerned about that for the mental health of our children. So yes, this is a topic that we should discuss together and decide together on how we should proceed. So again, welcome to this webinar, and especially to our resource speaker today, Dr. Anna Ong-Lim. So good afternoon, everybody. Thank you.
Thank you, Father King. And now may we call on SJCS Alumni Association President, Mr. Johnny C., to give his short message.
Good afternoon, everyone, and thank you for joining us today. This is as Father King mentioned, a very timely topic. We are very grateful and proud of the fact that we have been collaborating closely with both the St. Jude Catholic School as well as the parents auxiliary groups of the school in many ventures. And as Father King mentioned, we have conducted several webinars from mental health to other health-related issues. And we coined the term health talks because we believe the opportunity to share knowledge about the current issues about health is going to be a constant requirement, not only for the parents auxiliary group, the students, for the general alumni and Judeanite community as well. So we're very grateful for the fact that the cooperation level is very high. We're very grateful for Dr. Anand that she accepted our opportunity our invitation to speak in this webinar. I understand she's very much in demand. Dr. Marco was saying that she's part of the task force, IETF task force for vaccination. And so she constantly goes on air. So you have a celebrity in front of us right now in terms of the subject matter experts. We're also very grateful to all the parents auxiliary group officers. Father King was mentioning the fact that there is a lot of talk about the opening of schools for face-to-face. In fact, starting tomorrow, the Department of Education will be piloting the first 100 schools, public schools and private schools in face-to-face. So that will determine the course of action moving forward. I mean, I think it's fair to say that today it's a very, very important topic, not only because of the health concerns, but because of the efficacy of our schooling systems today. Today also, as part of our continuing evolution in the Alumni Association, we're very grateful for the fact that you will meet for the first time our newly elected president of the St. Jude Catholic School Alumni Association, who will assume her role as president at the start of next year. And this will probably be my last official function as part of the webinar series. But we will continue to help with the Alumni Association, and we hope that the new president, Stella Malincia, will continue also this path because I think the continued cooperation and close relationships we have with the school and the Parents Auxiliary Group will be a major boost and benefit to all of us. So thank you for joining us. I hope you gain a lot of information and knowledge and insights, and will help you in your own decisions versus what's best for our kids, best for your children, and best for the school. Good afternoon and enjoy the webinar. Thank you very much.
Thank you, Mr. President Johnny C. And now let us have Ms. Rachel Garcia, our high school Parents Auxiliary Group President, to represent the SJCX PAG to give her short message.
Good afternoon, Reverend Fathers, Dr. Ong-Lim, St. Jude Alumni, fellow parents, teachers, students, St. Jude commissionaries, and friends. We have always thought that the COVID-19 pandemic can only affect adults. However, due to the new Delta variant, children are also being affected. There are reports about children being hospitalized or quarantined, depending on the severity of the symptoms they experience. As parents, we are worried on how we could further protect our children, aside from the usual wearing of masks, washing of hands, and frequent disinfection. Therefore, we are grateful for this COVID-19 vaccine health talk by our distinguished speakers for us to be knowledgeable on the importance of vaccines as an added protection, not just for our children, but also for the entire family. Thank you.
Thank you, Rachel. Today's health talk is entitled COVID-19 Vaccines Cha-Cha-Cha. Should children be vaccinated? This is a very timely discussion, especially with this pandemic and now that the government has started vaccination for children. 今天的讲座主题是新冠疫苗。近期，菲律宾政府已开放让12至17岁的儿童接种疫苗。许多家长仍对是否让自己的孩子接种疫苗有顾忌和疑虑。今天请来的不但是一位儿科专家，他也是菲律宾国家疫情跨部会中心的顾问之一，相信他的解说能为大家解惑。Now, may I also introduce one of my co-hosts for today, a fellow Judeite from class 1978, a surgical oncologist at the Manila Doctors Hospital and an associate professor for surgery at the University of the Philippines, Manila, Philippine General Hospital. Let's all welcome Dr. Mark Ko.
Thank you, Shirley, and I'm so overwhelmed by your impeccable Mandarin that I cannot help but be awed at our and how lucky or how fortunate our Alumni Association is having you as a host as well. Let me just as a co-host, you are able to introduce me. Let me introduce you and a little bit, if you may, if you please. Shirley, of course, is a fellow alumni and she comes from class 1994, not so far from my own batch. She is active with our school still, being the secretary of the Parents Auxiliary Group, and has been class and level reps for her for the grade 8 level. She's a proud mother of 3, having Alexi, Anthony, and Avery. I hope all Judenites.
Yep,
and
all
as her, she also has an academic position, being a faculty member of the LaSalle College of Computer Studies. So kudos to you, because my wife is from LaSalle, so I can't say anything about LaSalle, only that it is great, of course. And you also serve as a Chinoy TV host. So congratulations to all these positions, and we're so lucky to have you as well. And thank you for having me.
Thank you. Wow, that was a wonderful introduction, Dr. Mark. So, how are you, Dr. Mark? How can you talk? Can you give us maybe your insight on what's happening right now with this pandemic?
Right now, I think we're all a little bit confused, but but very happy that our COVID numbers have come down. And I think the way we got here was because of our vaccinations. No? And so we're very lucky indeed to have Dr. Anna with us to speak more about the vaccines and about our current situation.
Okay, before we introduce Dr. Anna, let us also welcome our co-moderator for today. She's the head of Medical and Dental Clinic at the St. Jude Catholic School, and she's also the consultant at the Chinese General Hospital and Medical Center. Let's all welcome Dr. Ellen Tanco.
Hi, good afternoon.
Hi,
Pleasant
Ellen.
Sunday afternoon to everyone. Firstly, I would like to commend the St. Jude Catholic School Alumni Association and the Parents Auxiliary Group for sponsoring yet another of a series of health talks. This afternoon, we are very fortunate to have an esteemed expert in the field of pediatric infectious diseases to give us a very timely talk about COVID vaccination in children. We know that vaccination is the best way we could put a stop to the ongoing COVID pandemic, which has already claimed many lives. No? Now that a majority of the adults in the NCR and in some of the provinces have been fully inoculated, we are shifting our focus to our children. And as the government is easing some of the restrictions in our health protocols, and as most institutions are preparing to transition back to hybrid or face-to-face learning, the COVID vaccination program for the pediatric age group is really vital. So I'm sure everybody's excited to listen to our speaker for this afternoon. Thank you, Shirley.
Thank you, Dr. Ellen. Now, I'm sure everybody's already excited and eager to hear what our resource speaker will discuss about our topic for today. So, Dr. Mark, can you please give an introduction to our resource speaker for today?
Thank you, Shirley. Indeed, we are very fortunate to have a very active and busy colleague of mine from the UP College of Medicine. Dr. Anna is a professor and attending pediatrician at the University of the Philippines and the Philippine General Hospital. She is a fellow of the Philippine Pediatrics Society, where she serves as a member of its board of trustees. She is also the immediate past president of the Pediatric Infectious Disease Society of the Philippines. She received her MD or medicine degree from the University of the Philippines and completed her residency in pediatrics and a post-residency fellowship in pediatric infectious disease also at the UP Philippine General Hospital, where she is now chief of the Division of Infectious and Tropical Disease. As part of the Philippines' COVID-19 response effort, Dr. Ong-Lim serves as a member of the DOH Technical Advisory Group, the IATF Technical Working Group on COVID-19 variants, as well as the Interim National Immunization Technical Advisory Group for COVID-19 vaccines. Dr. Anna has published extensively on pediatric health and infectious disease and is heavily involved in clinical trials of pediatric vaccines, including those for measles, mumps and rubella, polio, pneumococcal disease, and influenza vaccines. She is also a regular speaker on topics related to pediatrics, infectious disease, vaccines, and clinical trials in the Philippines and throughout Asia. Ladies and gentlemen, it is my great honor and pleasure to introduce Dr. Anna Lisa Ong-Lim.
Good afternoon, everybody. Good afternoon to the St. Jude community. Good afternoon, Father Belamide. And thank you, Shirley and Dr. Mark, for the kind introduction. What Dr. Mark omitted to say is that I am his proud patient. 9 years ago this month, I went under the knife, and through his skill, I'm still alive to tell everybody that breast cancer is beatable if you have the right doctors. And a lot has happened since then, including my involvement in the COVID-19 response. So once again, I'd like to thank the St. Jude community for this very kind invitation to speak to you about pediatric vaccines. I think this is really a very hot topic because, as you know, the rollout has just started. I'm sure there are many questions in your minds about whether these vaccines are necessary, appropriate, and what are the best options for your children, and also alluding to what Father Belamid has mentioned, what will be the impact of vaccination on eventual face-to-face classes. So what I'd like to do for the next few minutes is basically just to walk you through a little bit of the current situation, and then go on to how we can help kids become protected, and talk a little bit about vaccines, and leave a lot of time later on for your questions, because I think this is really more appropriate. It will be more helpful to the community for your questions to be directly addressed. So let me just get my slides online there. And as I mentioned, what I'd like to do is just basically answer two questions. First, where are we now? And talk about what has been the impact of COVID on children. So when we talk about where are we now, we're basically reviewing epidemiology. There. Am I back online? There. Okay. So I just like to walk you through the epidemiology and share with you the latest numbers. So this is what the World Health Organization has online as of this morning, where they say that almost 200 or more than 250 million cases have been confirmed globally. And among those 250 plus million cases are 5 million deaths. So these numbers are really hard to wrap our heads around because they're so abstract. They're really huge numbers. But one way to understand the impact of at least these deaths, is to imagine that a jumbo jet crashing every 14 seconds for the next 24 hours equals 5 million or so people dying. So those are horrible numbers. And it's really these cases and deaths that is prompting global health authorities to try to figure out what the best response is to get all our lives back on track again. The numbers for the Philippines are, of course, not as huge, but still quite concerning, in that we already have more than 2.8 million cases recorded for the country. One additional information that I'd like to point out is that when we started the Burr months, not only did this signal the start of the Christmas season for our country, but it also marked the milestone of our 2 millionth case. And just between the month of September, October, and now the middle of November, just 2.5 months period of time, the numbers rose by more than 800,000 cases. So this very fast exponential increase is shown in the bottom part of the slide, where we have a very steep rise, which peaked during September and October. And we're blessed to be at the tail end of the surge now, with our weekly figures represented by the bars consistently being below the solid line, which represents the 4-week moving average. So for as long as we see this pattern, the bars always being found below the solid line, then we can expect the decrease to continue. Now, of course, those numbers tell only a part of the story. And what we really want to focus on will be the number of active cases, and specifically, which among the active cases are classified as moderate, severe, or critical, because they're the ones who will be utilizing healthcare and they're the ones who will end up in the hospitals. So we now have about 29,000 cases considered active. Basically, within the past 14 days, they had just turned positive. And so we assume that they're still either undergoing isolation or still in the hospital. Now, among these 29,000 cases, most are still classified as asymptomatic or mild. And if you total the percentages, this is a little bit under 70% at the moment. Typically, the distribution for asymptomatic mild cases covers about 80% of the total. And seeing this number of under 70% contrasts greatly with what we expect. We also see more moderate, severe, and critical cases than the usual 20% that we expect to be recorded. Here we have almost 30% of our cases still belonging to this group. No? So why do we have this proportion coming up in contrast to what we expect? I think it's not as much a problem of seeing more severe cases or more critical cases being documented, as much also as our behavior with respect to testing. I'm sure we know a lot of people who have opted not to be tested anymore and have just decided to stay home, isolate at home, or for their family members to quarantine at home rather than subject themselves to PCRs. And because that impacts on the denominator, then those people who happen to be accessing healthcare because they need to be admitted will be represented in greater numbers and thus showing up as the moderate, severe, or critical cases. So in any case, the point here is that since we're seeing this group of people being represented in our statistics, then the country or the different local government units have to be ready to be able to accommodate these numbers of people in our healthcare facilities. Now, this sudden increase that we picked up at the end of August and the start of September really coincided with Delta cases being picked up in the country. Delta first started being identified in India in May of 2021. And very quickly thereafter, it overtook all the other variants of concern that were being detected in other countries like Alpha, Beta, and Gamma. Alpha is the variant that used to be called the UK variant. Beta used to be known as the South African variant, while Gamma used to be called the Brazilian variant. Delta originally was referred to as the Indian variant before WHO transitioned to the Greek letter nomenclature that we all use now. So going back to the story of Delta, this was first picked up in India, was most likely to be responsible for the horrendous increase in numbers that they had and the really terrible numbers of deaths that they were recording. And in the span of about 2 months, it made its way all over the globe, including the Philippines. We picked up our first cases at the tail end of July of 2021. And this 2 month lag that we had, being able to keep it out of our borders, is actually, I feel, quite a significant public health accomplishment because the very strict entry requirements obligating our returning travelers to have facility quarantine was most likely very instrumental in making sure that we kept Delta out of our borders for as long as we possibly could. Of course, we know that this system isn't perfect. There are people who will be able to find a way to skip quarantine or isolation. And over time, cases that no longer had any link to travel was picked up in the community. such that by July and early August, there was a declaration of ECQ, reimposition of ECQ in the country, or in the NCR at least. And this was really coming from the observation that more and more cases were being picked up without a link to travel. So here we see that the Philippines is colored dark blue, which means that we also have Delta variant circulating in the country. And going back, those numbers that we saw in the earlier slides really coincided with the spread of Delta throughout the country. So we now know, after going through the current or the more recent surge, that Delta drove a lot of the increase in cases. Now, what has been the impact of this most recent surge on children? This data set is also available on the DOH website, and we're able to document the age and sex distribution of the cases, recoveries, and deaths that's being picked up in the country. So we look at first the left portion of the slide, documenting the cases. The distribution that we have in the Philippines is similar to that of what is being seen in other countries, where most of the cases are clustered in the working age population. This is very easy to understand because these are people who have more contacts outside the home, more exposures, and therefore more risk for being infected. What we see here is that the pediatric age group covered by the age bands between 0 to 19 years old represent one of the smallest groups of individuals affected by COVID, totaling about 12.5% as of 5 days ago. And based on the 4-year age bands, most of the cases are found in the 15 to 19-year-old age range. Now, I'm sure you're all aware that pediatrics only covers up to age 18. And this is really just a peculiarity of the way the data is documented. And in fact, if you piece out the 15 to 19-year-old age range, the majority of this 129,000 cases belong to 18 to 19 years. And again, this is easily understandable because many in this age group are already working and have the contacts that predispose them to risk of infection. Now, moving on to deaths, if the case distribution is a diamond-shaped figure, deaths typically take on a triangular or pyramidal distribution, where the base, making up our elderly or senior population, being disproportionately represented in terms of deaths. So currently, we have about 1.7% of the deaths being classified as belonging to the pediatric age range. We haven't even hit 1,000 cases yet, no? So we're blessed by those figures. And if you will look at the distribution based on age, the majority belong to the youngest age cohort, 0 to 4 years. And actually, most of them belong to the age group of 0 to 1 or 0 to 12 months. Now, looking at a little bit more detail for these cases, the Pediatric Infectious Disease Society of the Philippines actually started a passive surveillance case registry at the start of the pandemic. We call it the Surveillance and Analysis of COVID-19 in Children Nationwide, or the Salvation Registry, named after one of our mentors who was one of the first physicians who died from COVID. This is Dr. Salvation, or Dr. Sally Gatchalian. So this passive reporting system so far has captured about 1,800 or so cases as of September. And the age and sex distribution actually mirrors that that is being reported in the national database. The majority of cases being reported into this tracker belongs to those between 0 to 4 years. And most of our patients actually are classified as recovered. Now, because this is a passive system, meaning we don't obligate everybody to report. We ask people to volunteer their cases and give us the details so we learn more about this pediatric cases. Then the disease severity classification or distribution may not necessarily accurately capture the whole range of cases that we're seeing. But we do see a higher representation of the moderate, severe, and critical illness into this database. This is understandable because these are the cases that we see in the hospital who are referred to us as pediatric infectious disease specialists. What's remarkable is that many of the kids who are in this registry also have comorbidities. And if you look at the rundown of these comorbidities, they're similar to what we see in adults who are at risk for severe and critical disease. They have immunocompromising conditions like cancer, they have heart disease, kidney disease, they have neurologic disorders, they are obese, and we also have asthmatics being represented in this list. The symptoms that are seen in kids presenting with COVID are also similar to the symptoms that are commonly reported in the scientific literature. We see fever, cough and colds. Of course, a great proportion of them will probably already have difficulty breathing because that's when they start presenting to the hospital. So nothing very unusual in this particular distribution of symptoms. And perhaps what's remarkable here is that despite the fact that we're looking at symptoms now ascribed to different variants, they basically present in still the same way. Now, having gone through the epidemiology and the clinical presentation, we now know what the numbers are, what they mean, how they've impacted on children, how children present. We're now ready to look at how can children be protected. So to be able to answer that question, we need to understand, again, how is COVID transmitted in the first place? So this diagram helps us visualize the transmission cycle. And we see here that an infected individual who coughs, sneezes, or even just talks or breathes can actually disperse a lot of different sized particles into the air. We see droplets represented by the larger circles because they're bigger particles, heavier, are able to float only over shorter distances and stay afloat only for a short period of time. In a few minutes, you expect these droplets to fall onto a surface. And when we have direct contact with that surface, either from inanimate objects or from close contact with the source case, then this becomes a way by which we inoculate ourselves, by which that virus can enter our bodies through our eyes, nose, and mouth if we have hands that are not clean. The other way by which the virus can be transmitted is through airborne transmission. Aerosol particles or aerosolized particles are represented in this diagram by the small circles. They are lighter. They are able to float over a longer distance. They can stay suspended in the air for a longer period of time. And so this poses a danger to us if it continues to circulate in an enclosed space because we can breathe it in and it can infect us. So along or across these different methods of transmission, droplet, fomite, or aerosol, the more significant methods or portals are actually the droplet and aerosol transmission. Fomite transmission can seem to be something we need to defend ourselves against, but this needs a perfect storm of events for it to be an effective way for transmission. You need to have enough of the virus particle on the surface, surviving for enough time, and being transmitted to the correct portals for this infection to happen. So it's quite complicated for objects to be the source of transmission, and in fact, it is not considered to be a very significant portal through which we get the infection. we need to be more vigilant in terms of protecting ourselves from droplets and aerosols, because this is the most efficient and effective way by which the viruses gain entry into our systems. So with an understanding of the portals of transmission, we can now understand why there is such an emphasis on simple measures, no, that we capture with the acronym APAT DAPAT. So we have always emphasized always wearing a mask and shield, physical distancing, and being conscious about the time of interaction. However, if you think about it, these are all very much based on behavior and compliance. And because of that, they are classified as the least effective methods in the occupational and the health and safety hierarchy of controls. Because if you insist that somebody should wear PPE consistently, or you change the way people work, or impose some kind of engineering controls, this will still be dependent on people's compliance. However, when we are going through the higher levels like substitution or elimination, then independent of behavior, we can count on these measures to be able to effectively protect us against infection. And this will take the form of focus on vaccination as well as ventilation. So let me just talk a little bit about ventilation so that we know how we can utilize this maximally in our homes and workplaces. We want to be able to focus on fresh air, flowing air, and eventually filtered air if the first two are not available. So when we talk about fresh air, we want to bring the outdoors into the building, into the home, into the workplace by constantly renewing a source of clean air. And this is basically just making sure that by opening your doors and windows, you achieve an efficient air exchange. In the hospitals, there is a set standard of 6 to 12 air exchanges that is targeted to ensure that we are able to impose proper ventilation. And this typically requires complicated computations. But there's a way to actually do this in a more practical manner in our own homes and workplaces. We all know that when we exhale, we release carbon dioxide. And in a workplace or a home setting where the carbon dioxide levels are high, then the only conclusions you can draw are, first, there are too many people in that room, which is bad, or the circulation is not adequate, which is also bad. So what you want to be able to target is a number that's less than 800 parts per million of carbon dioxide. And even better, target 400, because 400 is the level for outdoor air. How about flowing air? So we said we want to bring the outdoors into our enclosed spaces, and we want this outdoor air to be circulating thoroughly in the indoor environment. Once again, by making sure that the doors and windows are open to the extent possible and utilizing something that we all have in our homes. I'm sure we have more than 1, 2, 3 electric fans and exhaust fans in our homes and offices, and we should be running these as frequently as possible. You want to direct the fans outside onto an open window away from people so that this allows for particles to be dissipated to a larger space. Let me just show you the impact of ventilation on these two settings. No? The top portion of the illustration shows a room with poor ventilation without an open window or fans, or the absence of filtration systems. You can expect that particles will continue to circulate, but in contrast, with good ventilation, then whatever particles are in the air can rapidly be dispersed. So going back, if we don't have access to fresh or flowing air, then filtered air can be helpful by removing contaminants from the indoor air spaces. And we are very much aware of HEPA filters being available. But I would like to caution everybody that when we secure these HEPA filters, we need to make sure that they're appropriate for the space that we are deploying them at. And the rule of thumb is to look for a device with a rate of at least 300 per 500 square feet of space. So it's not a one-size-fits-all device. No, we have to ask a manufacturer or the distributor whether the device we are purchasing or deploying is appropriate for the space that we will be using it in. And there's a recommendation to upgrade to what are called MERV 13 filters because they're even more efficient at filtering the air from these contaminants. Okay. Now, I mentioned in that hierarchy of interventions that we want to focus on controls that will eliminate the risk of exposure. So first, we talked about ventilation. Now we talk about vaccination. Vaccines are basically just a way to get our immune system in shape, to train it to recognize the virus or bacteria before the actual encounter happens. And the training takes place when the body gets introduced to the organism in its weakened or inactivated form. Para lamang na lamang yung ating immune system and it can definitely fight against the pathogen. So this killed organism or parts of this organism are what we call the antigens. You put them inside the formulation of the vaccine, inject it or spray it into the person, and after this introduction, the immune system is able to recognize the antigens and produces two forms of defense, antibodies as well as cellular immunity. Together, this will be on standby so that when the actual virus comes along, it is capable or they spring into action and are able to defend the host, the body, from the risk of severe disease, the risk of critical disease, and to decrease the risk of death. So these are the objectives of COVID-19 vaccination. At this point in time, we are not yet able to say that being vaccinated against COVID will prevent you from being infected. But decreasing the risk of severe critical disease and decreasing the risk of death are very significant, very valuable outcomes that we are happy to have because it improves our protection. So currently, there are many, many different platforms that are utilized for the vaccines that are available globally. There are whole virus vaccines. We have what we call the inactivated vaccines, to which the more familiar brands from Sinovac and Sinopharm belong. And we also have our component viral vaccine. So this lineup looks very extensive, but what we have right now are the RNA-based vaccines or the mRNA vaccines produced by Pfizer and Moderna. And we have the non-replicating viral vector vaccines, such as the ones that are produced by AstraZeneca, Janssen or Johnson & Johnson. And we also have the Gamaleya vaccine known as the Sputnik vaccine from Russia. Very recently, we also had the Covovax vaccine that was also released by Bharat globally, and this also belongs to the inactivated category. So, at the start of the pandemic, global health experts were really looking towards vaccines as being part of the big picture solution to be able to control the pandemic because we realized that for many infectious diseases, vaccines have really changed the game in terms of preventing transmission and controlling disease spread. That's why we're no longer afraid of getting polio. People don't die of rabies anymore. We have very few people who get complicated measles or chickenpox. And all of these vaccine preventable diseases are really just stories for many of us now. And in the same way, vaccines have proven to be highly effective against severe illness and death, even caused by variants that are known to be highly transmissible and very deadly, like the Delta variant. These graphs show us what has been happening globally. In countries that have been highly vaccinated, or rather in countries that have not yet achieved sufficient vaccination. So for example, here we see Namibia at 1.2%, South Africa at 2.5%, Indonesia at 5.8%, even Russia at 13%. The cases that they report, represented by the blue portions of the graph, are followed shortly thereafter by deaths, as represented by the red portions of the graph. So typically, what you have in terms of cases will be about the same as the number of deaths that you expect in 2 weeks' time. Now, what's the story when it comes to these highly vaccinated countries like the UK or Portugal? At the time that this graph was generated, they had covered about 40-50% of their population. We see that in the past, prior to vaccination, of course, they had a lot of cases, as is the same as was being reported in other countries globally. When vaccines were introduced into their populations, if you look at these gray portions of the graph, their numbers decreased. And not only did their numbers decrease, we no longer see significant mortality being represented in their reports. So not only did we see that vaccines had an impact on disease transmission, it also had a significant impact on deaths. And in well-vaccinated countries, the surge in cases no longer was mirrored in deaths, whereas in countries with few individuals being vaccinated, the death rates have still reached record highs. So the same information is seen in this graph coming from the data being reported by the National Statistics Office in the UK. Of the deaths between January to July of 2021, 37% were unvaccinated. About 20% were within 21 days of the first dose, meaning they were still not yet fully vaccinated. And you have decreasing numbers being represented among those who are partially vaccinated or fully vaccinated. So I think the takeaway here is that it's not reasonable or it's not realistic to expect that deaths will go down to zero, because that is not what vaccines are expected to do. But we do expect vaccines to be able to decrease the risk of severe and critical disease and decrease the risk of death. And that is what we are seeing globally. Now, because vaccines initially were available only for the adult population, what we used to protect children was the cocoon strategy. This is something that we also do for other vaccine preventable diseases. We target the age populations that are most vulnerable and give them the vaccines for their own individual protection, as well as to protect the vulnerable populations in their households who are not yet able to receive the vaccine. So, for example, when we think about infants, newborn babies, we know that they cannot be vaccinated against some of the diseases that they can be exposed to. But we want the family members to be protected so that the babies are also protected. So we use this same strategy for the pediatric population at the outset. We ask the adults, the vulnerable adults, to be the ones to be vaccinated so the kids can be protected. And that strategy was quite helpful at the start, but with the availability of vaccines in the 12 to 17-year-old age range, the Philippine Pediatrics Society and the PIDSP, or the Infectious Disease Society of the Philippines, talked about approving and recommending vaccines for the 12 to 17-year-olds after we have adequately covered the vulnerable adults, those who belong to the senior category and those who are in the category with comorbidities, recognizing that different strategies need to be put in place so that kids can be protected as well. So the statement that was released in September mentioned that adults and the more vulnerable age group should still be prioritized. And once enough supply is available and we've been able to cover the vulnerable adult population adequately, then we can go to the 12 to 17-year-olds, prioritizing first those with comorbidities and going to the general population. So that's what we're doing now. And I'm sure you've already heard, and maybe many of your families, the kids in your families, have already been vaccinated following this strategy. Now, lately, there have been reports coming from global health authorities as well as the local authorities about an adverse event following immunization with the mRNA vaccines. And this is what you call myocarditis, or in layman's language, this is heart inflammation. So there is actually a system in place that captures what we call adverse events following immunization. And that's the reason why we have this information at hand and why it's being explored. We have now rolled out billions of doses of COVID-19 vaccines globally. And for many countries, there's a tracking system that looks at the cases of adverse events that are being experienced by vaccinated individuals. Now, for adolescents, for teenagers, there have been very rare reports of myocarditis. And currently, the available data suggests that there could be a relationship between these symptoms and the mRNA vaccines. So what do we expect to see? These very rare cases of myocarditis present as new and persisting chest pain, shortness of breath, and palpitations or a racing heartbeat. Typically, these symptoms will be experienced within a few days of vaccination, usually after the second dose. And in many cases, people recover completely with treatment and rest and don't have any long-lasting symptoms. So therefore, the current recommendation globally is that the benefits of our mRNA vaccine still greatly outweigh the risk of this heart inflammation. And so we continue to recommend vaccination. So when we talk about very rare, how rare is very rare? Let's look at this table to appreciate the numbers. Up until June of 2021, almost 300 million mRNA doses had been administered in the US. And this is the data captured by their VAERS, or their Vaccine Adverse Events Reporting System. They had about 1,200 cases of myocarditis out of 300 million doses of the vaccine. Most of the reports came after dose 2, and if you compute the risk, this is 0.0004%. A very, very tiny group of individuals who have felt the symptoms that I described earlier, and most of whom have been or have recovered spontaneously with very minimal intervention. Is myocarditis something that you expect only after vaccination? Actually, it is a risk also for COVID-19. I'm sure as parents, you have also heard of MIS-C, or multi-system inflammatory condition in children, no? Which is similar to another inflammatory disease in kids called Kawasaki disease, but associated with COVID infection. So COVID in itself and the impact of COVID, or the side effects or the complications of COVID, bring with it a 16-fold higher risk of myocarditis. So the disease itself is more likely to cause myocarditis than the vaccine. So once again, if we look at risk versus benefit, the ratio favors vaccination. And lastly, if I can just share with you another set of numbers, for females, you prevent all of these cases of hospitalizations, cases, ICU, admissions, and death at the expense of 8 to 10 myocarditis cases, while for males, the numbers are also quite significant for about 60 myocarditis cases encountered. So this is why we say this is primarily something that's been observed in males, but once again, in very, very, very low numbers. So I started off this talk with two questions. First, where are we now? And I hope with this presentation, I've been able to share with you the fact that we are now at the tail end of the surge. The numbers are going down. Things are looking more hopeful. And we see that this will really be sustained over the next few months. What has been the impact of COVID on children? So we still see very low numbers in terms of the pediatric population. Cases are about 12%. We have 1.3% in terms of deaths. But the larger impact is something that we also have to keep in mind. We have kept our children indoors for almost 2 years. Their growth and development has been significantly affected. And unless we find a way to be more efficient in protecting them, we might not see an immediate effect on their health in terms of preventing COVID, but the long-term consequences on their development as individuals and the development of our communities will be very difficult to predict. And so for vaccination programs globally, aside from the goal of preventing severe and critical disease and decreasing the risk of death, for children, vaccination has also become an issue of giving them the opportunity to become the best versions of themselves. And I hope now with this in mind, we will be able to carefully consider whether or not our kids should be vaccinated. So with that, let me end my presentation. Thank you for your attention and turn the floor back to our moderators and our hosts. Thank you.
Thank you, Dr. Ana, for a very clear discussion regarding the virus COVID-19 and the vaccines and vaccination. We will now have our question and our answer portion, and may I also invite Dr. Mark and Dr. Ellen to join us. 现在我们进入提问环节，直播间的朋友们，还有 YouTube 的观众们，你们可以在聊天框上输入你们想问的问题。So for our viewers who are with us in YouTube and for those who are here with us in Zoom, kindly post your questions in the chat box or the comment section so that we can read and raise these questions to our resource speaker, Dr. Ana. So I think we have a few already at the start. So may I request Dr. Mark to raise the questions?
Thank you, Shirley. I'm so happy that I am not in the college node. Dr. Ana and I sometimes will be assigned as rapporteurs, and we have to make a summary of the talk just done, and it will be such a task for me to make a summary of such an elegant presentation. So thank you, Dr. Ana, and thank you for highlighting cancer, which may not have as much in terms of incidence, but certainly the mortality rate for cancer is much higher, and it begs the issue of awareness for everybody, not only for COVID but also for cancer. And I'm also very touched by the infectious disease, pediatric infectious disease society for naming one of their projects Salvation. I know Dr. Sally very well, and she's also my mentor, and we share the same barber, in fact. And it was such a sad thing, when she such a sad event that she passed away due to COVID. Again, so thank you. There are a few questions that we have for you, Dr. Ana. And the first was regarding the statistics on COVID mortality. Yes, you answered it, but perhaps the the question may be why, the mortality is low. Why would the mortality be low in children or in the pediatric age group compared to the adult group?
So that's actually a very interesting question. And it's something that scientists have attempted to answer. So one of the things that has been pointed out is the fact that the airways of children are lined by, or the receptors that are found in the airways of children have less of what is called the ACE2 receptors. And that's actually the lock into which the virus enters as a key. So if you have fewer locks, then you have less of a chance to be infected, theoretically, and perhaps that lower viral load that kids seem to be getting might have an impact on the disease severity that they're presenting with. But this is all still very hypothetical. We need to understand this virus and its behavior even better to come up with more effective treatments and more holistic explanations.
Yes, and maybe perhaps what area of research could be on those receptors if we can decrease that number of receptors in adult nasal passages.
Yeah.
The other question was regarding vaccines. Will the vaccine alter the hormones of the kids, especially those undergoing puberty, and will they need a booster shot? These questions are coming from Shirley CSC.
Okay. So with respect to altering the hormonal patterns of recipients, not necessarily just kids, right now, there isn't any direct evidence of that happening. And for some of the platforms where we have a lot of experience, like the inactivated vaccines, maybe just to mention some of the other vaccines using this platform para we're more familiar with it. We've all received hepatitis B vaccines, We've all received flu vaccines. We've also received, what else? Pneumococcal vaccines. These are all inactivated platforms, And none of these platforms have been associated with hormonal changes. For the newer technologies like the mRNA vaccines as well as the viral vector vaccines, they also have not been associated with hormonal disruption. So there's also not a lot of theoretical basis for that to happen. Kaya that's not as much of a concern with respect to adverse events. Now, the second question about boosters, currently that's being studied very intently. I think first we have to differentiate, are we talking about a third dose or a booster? Although it sounds very technical, there's an impact, there's a implication to that answer. Kasi if we're saying that what we need is a third dose, then that means that all of us actually need another dose and we need to complete the series. If we're saying it's boosters, then theoretically, you would think that perhaps just certain groups of people will benefit if they did not have a good response. So currently, the thinking is that only select groups of individuals should be receiving additional doses. Let's just use that general term. And this will include those people with weakened immune systems, including those on chemotherapy, with cancer, on steroids, and so on.
Thank you, Dr. Ana. Another question from Val Estejada. Is Pfizer the only vaccine that is approved for kids? And although you talked about myocarditis as well, and you showed the chances of getting myocarditis in teens. I think it was 4 in a million. How about do you foresee that in the younger age group, below 12? I think that's where the question is coming from. What are the chances of these children getting myocarditis?
Okay. So currently, the only vaccines with emergency use authorizations for the pediatric age group, 12 to 17, are Pfizer and Moderna, both in the mRNA or using the mRNA platform. Very recently, I think just in the past 2 weeks, Pfizer also got an emergency use authorization for the 5 to 11-year-old age group. It's a very recent recommendation. Now, in the Philippines, we only still have EUAs for Pfizer and Moderna and only for 12 to 17. There are people who are accessing the public programs now and they're saying, 11 years old yung anak ko, bukas siya magba-birthday, bakunahan mo na ngayon, hindi ba yan pwede? And of course, our system will say, hindi po yan pwede. Kasi, unang-una pa lang, when you enter the data into the base, into the computerized recording system, it will not accept anybody below the age cutoff. It's intentionally built in. But they're not just being mabusisi about it or nitpicky. It's really because the 5 to 11-year-old dosing format is different from the 12 to 17. No? So they're not just being mabusisi or being straight-laced about it. No? There really is a reason. So kung hindi pa 12, wag muna kasi it's a different vaccine. But for the 12 to 17, you may receive, or 12 to 17-year-olds may receive both the Pfizer or the Moderna vaccines. The myocarditis in the younger age population is still just being monitored. We don't have enough information at that for that right now.
Shirley?
Okay, thank you, Doctora. Now, the number of cases for the past few days have been decreasing, no? Is it really reflective of the actual scenario since we still see lots of people, especially now that kids are allowed to go outside now, that we do not now really adhere to safety protocols, like some people are not wearing their masks or face shields properly. So can we really rely on the number of cases reported?
Okay, that's a very interesting question, Shirley. I prefaced the presentation earlier, is really that we're not capturing the data accurately enough, no? Because I'm sure we all have family members, people in our workplaces who have opted not to be tested. Alam natin yan. But we also know COVID ka, ano pa nga ba, di ba? So definitely there will be some degree of inaccuracy. But we're not just interested in the numbers, we're also interested in the trends. And we can't deny the fact that the trends have been going down. One of the things that we observe in the hospitals is that even before the numbers go up, your ERs are crowded already. I'm sure Dr. Mark and Dr. Ellen will testify to this, di ba? Pag pumasok tayo ng hospital, pag maraming tao sa ER, alam mo na may nangyayari. And that hasn't been the case lately. No? We've been able to fast-track our admissions into the wards, and that means that our turnover is much, much faster. So this downtrend, I think, is quite significant. It's reflecting in our healthcare utilization, and I really hope it stays that way.
Okay, thank you, Doc. And then what's the probability, like, for example, we when we go out, there are people who wear face masks, but not properly. So we are actually required to wear face shields, but now maybe the government will be thinking of not requiring face shields. So how actually is the face shield or the face mask effective?
Okay, so earlier in the presentation, diba, I showed this diagram about transmission. I think it's very critical for people to understand that properly so that it gives us our motivation to consistently wear our PPEs. The main routes are really still droplet and aerosol, and it enters, or those viruses enter our body through the mucous membranes of the face, the eyes, the nose, and the mouth. So that's why we want to cover this part of our face. If you think back to the time when vaccines were not available and us doctors only had PPEs to protect us, no? Just by consistently wearing those PPEs, we were able to avoid infection. So I think that really testifies to how effective they are if it's used correctly. And I'd encourage the public to be able to benefit from this by consistently wearing their PPEs correctly as well.
I have
Sige, go Dr.
Okay. I'm sure some of our parents here are very concerned to know about, are there any contraindications or absolute contraindications for the COVID vaccine in pediatric age group?
Right now, Dr. Ellen, the contraindications for pediatric vaccination are the same as the adult. So, a prior history of anaphylaxis to vaccines or vaccine components, or specifically to PEG, polyethylene glycol, or polysorbate, if that's been identified, will be contraindications to receiving the Pfizer vaccine. Now, since those are really very, very rare, basically we're saying that everybody who is up and about, who is medically stable, even if they have comorbidity, should be given vaccine. And in fact, in the Philippines, diba, who did we target first among the 12 to 17? It's actually those kids with comorbidities. Actually, nung dinidiscuss, if I may share, nung una kasi, there was a lot of hesitation from the expert panels to approve the 12 to 17 rollout. Kasi at the time when this was being discussed, and even up to now, di pa rin naman maganda yung coverage natin for A2 and A3. It's only NCR that has really good numbers. Everywhere else in the country, nakakahiya. It's really low. And then how can you justify covering your 12 to 17 when you have seniors and people with comorbidities who haven't been vaccinated yet? And you have your LGU saying don't have the vaccines, but you're vaccinating 12 to 17. It doesn't make sense, no? So anyway, going back, kaya pinili yung 12 to 17 na may comorbidities, mas may dahilan. So kung yung may comorbidities, kinaya nilang mabakunahan, syempre pati yung normal, mas kaya, di ba?
Because there are some parents who have been calling me. I think there was one case, her child got the first dose of Pfizer. Then a week after, because they are advised not to do any strenuous activity after the dose of the vaccine. So a week after the vaccination, the child had chest discomfort and palpitations, even at rest. So I think they have to report the case to for the adverse reactions.
Right.
But now the concern of the parent is she does not want the child to get the second dose anymore.
Yeah.
And she's asking if, in case any other vaccine will be approved by next year, can she take another brand of the vaccine?
Okay. So the current recommendation of our cardiologists, no, after such events are reported, is to wait for complete recovery, including monitoring of the cardiac enzymes, and then proceed with the second dose after recovery. So, why is that the recommendation? First, because the only information that we have regarding protection comes from 2-dose regimens. We don't have data that tells us that a single dose is going to be protective over the longer term. And we have very, very limited data on cross-platform protection. Definitely, there are no cross-platform studies for kids. Wala pang ganoon, no? So for us to say na, sige, you change platform na lang kasi you went through this experience, there's no basis for it. Now, the question, I guess, for this parent is, can you afford to wait 1 year? Kasi, sabihin niya, well, I don't want to take the risk. Okay, so can you afford to wait 1 year? The question there is, what will be the risk in the interval? Yun ang kailangan sagutin, no? Kung sasabihin natin the risk is manageable, then it will be reasonable to say, okay, I'll just wait for the next release of data and consider it at that point. But if we again go through the surge that we just had, where you had whole households going down with COVID, it's a different story, no? And the precaution naman that's being recommended, which is full recovery before receipt of the second dose, is quite reasonable. So those will be the talking points, I guess, no, that this parent will have to discuss with the physician for an individualized decision.
Thank you.
Doc, I have a follow-up to that. Since we're talking about the second dose, no, there's a question here. For now, for the Pfizer vaccines, after 3 weeks you get the second dose. So is it okay that we instead wait for 4 weeks or more to get the second dose instead of following the 3 weeks, or will the vaccine be already not effective because we did not follow the schedule?
So what's the reason, no, for waiting? What's the difference? Kung sinabi ko instead of 21 days, mag-antay ka ng 22 days or 23 days, di ba? There has to be a basis for changing the schedule. And currently, the data coming from the clinical trials is that these vaccines work best when given at 3-week intervals. There's no data that supports delaying the dose. And there's no data that says if you delay the dose, you manage the risks better. Walang ganong information. So currently, if you will parang take note of the way I'm answering these questions, it's all based on what the data is telling us. Yun lang naman ang pwede nating pagpasihan for now. So currently, the data is saying that these 2 doses need to be received, that the interval should be at least 3 weeks. There is data that says that if you delay or you miss your schedule, you may still receive the vaccine without repeating the first dose. But if you're intentionally delaying it just because you want to manage the possible myocarditis, there's no evidence that says delaying it will decrease the risk of that happening. So I guess that's why the recommendation currently is you should receive the doses as scheduled and then you observe, so that if the earliest signs of this very rare adverse event are observed, then we know what to do.
Okay. Dr. Mark, you have a list of questions with you.
Yes, Doctora, it's good. No, you also emphasized our principle of evidence-based medicine. When there's no data, then there's nothing much to comment on. No?
Right.
There's a question here regarding, this is in your opinion, with the current vaccination pacing in our country, when are we ready to do face-to-face classes, especially for children below 12 years old who do not have the vaccines yet?
Okay, that's a very interesting question. Kasi the premise there is that vaccination equals moving to face-to-face classes. But, we are one of only 2 countries globally that has not yet resumed face-to-face classes. I think the other one is Pakistan nga ba? Kung maalala, Pakistan or Afghanistan. Yung parang tipong, kakategory natin sila, nakakaawa naman tayo, di ba? So, in contrast, di ba, many countries have already resumed their face-to-face even before vaccinations for pediatric populations were started. So that only tells us that it is possible to uncouple the decision for face-to-face classes from vaccination coverage. Kasi tama yung tinanong ng participant natin Paano naman yung below 12? Paano pati yung below 5, di ba? Wala pa tayong bakuna for them. So antayin pa natin yung bakuna bago natin sila papasukin. Maka-high school na sila bago sila makapasok sa classroom, di ba? Sobrang tagal.
On the other hand, are you recommending it now or at a certain point when we reach a certain percentage of our target population or vaccination?
So yun nga yung point Parang hindi lang naman vaccination ang way by which we protect individuals from infection, no? And even if we vaccinate, all of these MPHS, the minimum public health standard, don't go away. So even as we're rolling out our vaccination program, it's good, it's available. We can also start looking at how we can resume face-to-face with the appropriate standards in place and changing the paradigm. I think we can no longer go back to the previous setting where you had 30 kids in a classroom. That's not possible anymore. I don't think we will ever, or we will go back to full face-to-face for the moment. Perhaps we will be hybrid for quite some time. We need to be able to be flexible because anytime somebody is reported to be positive, then that cluster has to stay home and get quarantined, diba? So all of these contingencies have to be in place. It's a very big demand on school administrations and teachers and even the parent community. We all have to work together to get this done because otherwise, if we just say, sige, antayin na lang natin bakunahan lahat, that won't happen.
Correct.
It really won't happen.
There's no magic even in College of Medicine.
Oh, yes.
Colleges
yes.
of medicine,
Yeah.
we are already resuming some face-to-face, and the interns have come back.
Yeah.
Students have come back, and
Yeah.
well, it seems to be good. But we hope that when we really fully roll out the strategy of that you're suggesting, that we do it, that we'll be able to do it. Okay. Another question here is: some countries only give 1 dose for minors. Some give 2, like the Philippines. Is 1 dose enough? And then should they get a booster later, or should minors complete the 2 doses too?
So going back to what we know from the data, the 2-dose series for the mRNA vaccines is known to be the complete package. We don't have data to tell us that a 1-dose vaccination program is going to be enough to protect this age range. We will definitely get an immune response. No? Ganun naman talaga ang epekto ng bakuna eh. But as to how effective that response is going to be, will it achieve the objective of protecting versus severe disease and death? Will it provide long-term protection? Will it require boosters or additional doses in the future? All of those are unknown. Kaya I think this participant is alluding to the programs that are already started in Taiwan and Hong Kong, where they're just giving 1 dose for their 12 to 17s. I feel that was actually taken in response to the relatively lower numbers that they have. So when you weigh risk and benefit, they'll say, okay, even if the risk for myocarditis is 0.000004%, okay lang yan sa akin kasi 1 dose lang ang ibibigay ko kasi sobrang konti. Diba? Pero kung maraming kumakalat na sakit, parang hindi mo yata kayang sabihin na 1 dose lang enough na. Eh di wag mo na lang bigyan kasi di mo rin alam kung after 1 dose may mangyayari, di ba? So parang ganun yung discussions. And right now, there's really not enough evidence to say that 1 dose will be enough.
Yeah, that highlights the problem with our country, that we don't have much funds for research and data gathering, and even within our own college in the UP system, we are lacking compensation for good people to stay on, and no funding for all these data gathering and research, which we all need. And so we hope that indeed it is through data that we're able to be able to get guidelines.
Yeah, I have some questions here. There are questions regarding, are there any other ongoing tests involving other brands of vaccines like Sinovac? Because I think they have been hearing, in China, they have been giving Sinovac already for 5-year-old and above. So are there any ongoing tests with other vaccines?
The clinical trial for pediatrics, Sinovac in pediatrics is just about to start. No? So actually the Philippine General Hospital is one of the trial sites. And the planned initiation visits will start within November. So very early days yet. The reason why I'm sharing these timelines is you can imagine if we're just starting in November, that's assuming we can start, kailan namin matatapos yung trials, di ba? Tapos, kailan natin ma-compile yung data gaano pa natin katagal bago matapos yung analysis? Maaga na siguro yung mid next year. So where is China getting its data from? I really don't know because they haven't published anything. And well, it's really their prerogative to roll it out the way they do. They have their own systems. But typically, for the global medical community, you have studies, you publish it, you share it with the public, and you invite everybody to review your data so that everybody's confident that this is going to work. And so far, there's nothing published on pediatrics for Sinovac.
Okay, regarding that one, the studies and exploring safetiness of the different brands like Sinovac. So for the Philippines, PGH is already starting to gather data about this one. How are there studies exploring the safety of giving other vaccines to minors? Because for now, what's approved is Pfizer and Moderna only. How about the other brands?
There are also studies on AZ. From what I heard from their research teams, they're almost done with their 12 to 17, their adolescent trials, and they're starting their lower age groups very soon. For Janssen, I think they're also completing their adolescent trials as well. So I think the point that I'd like to make is that if the goal is herd immunity, and we all heard that herd immunity, or the proportion of the population that needs to be covered should be at least 70%. No? Think about the fact that in the Philippines alone, about 40% of our total population belongs to the pediatric age group. So to get that 70%, you will need to vaccinate kids. And that's the same story in many other countries. So kailangan bakunahan ng mga bata, kailangan gumawa talaga ng mga trials to demonstrate safety and efficacy in kids. And this is coming along very quickly, and hopefully we will have that information to support the recommendations.
Okay. How about for babies? Like, for example, do they automatically get antibodies when they are being breastfed? And should the pregnant mother be given a vaccine? And then the other question, something related to this one, is if the mother has have been vaccinated already, will the baby automatically get the antibodies when breastfeeding?
Okay. So the current recommendation is that pregnant women starting the second trimester may receive vaccination. And the goal for this particular recommendation is to protect the mother first, because we have heard very sad stories where pregnant women have gotten severe COVID and have either died or their infants have died in utero because of the severe disease that they went through. No, so pregnant women may receive any of the available COVID-19 vaccines. Now, when infants are delivered, the majority of them actually are negative for COVID, even if the moms are positive. So it seems like there's some kind of built-in protection, for babies who are delivered to positive moms. When the breastfeeding mom's breast milk is expressed and tested, antibodies are found that are included in the breast milk. So, of course, if you're breastfeeding, you expect that antibody to be passed on to the infant. The missing part of the picture is we don't know what happens to those antibodies when the infant takes it in, because that's another study altogether. You have to follow the infants, check their exposures, and see whether if they got COVID, what kind of severity they had. But it's very encouraging because in many other vaccine-preventable diseases and infectious diseases, if the antibody shows up in the breast milk, the infants get protected. So there's no reason to believe that COVID will behave differently. We just need solid proof to say that that's what's happening.
All right. Dr. Anna, there's a question here, perhaps a little bit more on the anti-vax area. No? What can you say about Pfizer, since it's an mRNA jab and it affects cells of the kids, no, ng bata. Parang GMO daw, no? Makaka-affect ng normal cells ng kids, ng virus na pinasok sa bata. So, how does the mRNA being a synthesized, no, or laboratory synthesized strand of nucleotides, no? That how is this going to affect the normal cells and baka, again, the side effects, no, regarding this?
Well, siguro the way to answer that question is to understand how the mRNA vaccines work. The vaccine includes a very short strand of the genetic material of the virus. The reason why this has been selected as the formulation for the vaccine is because selecting these genetic material makes for a very efficient way to induce protection. That genetic material is covered with a fat molecule so that when you inject it, it doesn't get degraded by your body right away. And those very tiny amounts of genetic material find their way inside the cell, but not inside the nucleus, which is the headquarters of our genetics, the human genetics, no, which controls how we function and so on and so forth. The mRNA strand is only found in the cytoplasm. So kumbaga inside the house but not inside the bedroom. Doon lang siya sa sala. And then the goal of that mRNA strand is to get itself picked up by the factory, by the protein factory, so that those little bits of protein that are unique to the virus are expressed and produced. Konting-konti lang din. Kasi maiksi lang yung life nung laman ng vaccine. So sandaling-sandali lang siya, enough to just produce a little bit of the viral protein so that it becomes attacked by the immune system. So the mRNA coming from the vaccine stays in the system for, people have said, about a week, definitely not 2 weeks, not even 2 weeks in the system. No? So it stays there for a very short period of time, produces a tiny amount of the protein, which becomes the target of the immune system. So if that particular process, no, gives assurance that we're not expecting any alteration in our own genetic material after vaccination. And in fact, the billions and billions of doses that have already been distributed starting last year, December of 2020, no, in developed countries, have not shown any evidence that people's genetics are being altered by the mRNA vaccines.
Follow up on that. Because there are some parents asking, since Sinovac is an inactivated form of the vaccine, will it have lesser side effects as compared to the mRNA vaccines?
If you look at the safety profile of the different platforms, they're quite comparable to each other. And perhaps if you do your own informal survey among the people that you know who have been vaccinated, there are people who have tolerated the mRNA vaccines well. There are people who have tolerated the viral vector vaccines well, like AZ or Janssen. There are some people who have reacted very badly to the inactivated vaccines. So iba-iba. It's not only a question of the vaccine itself, but how people tolerate vaccines. And there are some people who just are really quite reactogenic, and there are some who have no symptoms at all. So, but overall, if you look at the data being reported across the different brands, the side effects, the adverse event profile is quite comparable. Dr. Ellen, siguro if I may lang, I think it's all very well and good to be aware of adverse events following immunization. But let me just emphasize 2 points. First is, we should not automatically conclude that anything bad that happens after vaccination is the fault of the vaccine. So there is a question of coincidence versus causality. So let me just use a very exaggerated example just to drive home the point. Let's say, si Father King, dahil natuwa siya, dami-dami nag-participate sa ating webinar today. Magpaparaffle siya. Tapos utusan niya si Dr. Mark. Sabi niya, Dr. Mark, itong 5 taong niraffolan natin. Saka ikaw, Dr. Ellen, puntahan niyo nga yan sa kanilang mga bahay at bigyan niyo sila ng flu vaccine, palibre ng St. Jude. Kasi syempre, natuwa na lahat ng mga nanood, di ba? Nagparaffle na. Dipunta naman itong si Dr. Ellen saka si Dr. Mark dun sa mga bahay, binakunahan nila. And following good practice, they observe the persons after vaccination for at least 15, probably 30 minutes before leaving the home. But syempre, the person wants to be hospitable and offers you something to drink, something to eat while you're waiting, while you're chit-chatting. Di punta siya sa kusina, di ba? Pagpunta niya sa kusina, bigla kayo nakarinig na bang, loud crash, nadapa si person. Would you think that that's related to the vaccination? Sabihin natin, of course not. Natapa lang siya eh. Diba? But, what will happen? Of course, naku, unfortunately, nagka-fracture. Dihin natin ngayon ni Dr. Mark sa ER. Nagka-pasyente pa siya. Ni-refer niya sa ortho. Nakuha na ng history na. Kasama pa dun sa history na binakunahan ni Dr. Mark ng flu vaccine. AEFI ba yan? Adverse Event Following Immunization. Makaka-capture yan. Kasi ganun ang sistema natin. Pero are we saying that the fracture had anything to do with the flu vaccine that you gave? Probably not, di ba? But if of all the 5 people that you vaccinated, ganun lahat, dinala mo lahat sa ER at nadapa sila, sabihin mo, naku, may problema yata itong flu vaccine na to. Bakit ganun? Hindi na siya coincident. Baka causal na yan. So parang that set of events can actually be happening on a large scale now. So many people being vaccinated, billions of doses being distributed, all sorts of events being reported. And the challenge for the system is to capture all of that and make sense of it. Because yung sinabi nilang myocarditis sa 0.0004% na yan, na-capture yun ng system. At alam na natin ngayon that we have to be watching out for it. So what's reassuring is that there is a system to capture all of these rare events. We are aware of these rare events. We know what they look like, and we kind of know what to do with it in most cases. So I hope in this very challenging circumstances that we have right now, where we have a really big enemy, we need to be able to balance all of these considerations. There's no perfect vaccine, and there's no risk-free intervention. But if we compare our risk versus benefits, typically, the medical interventions being recommended have a favorable ratio for the intervention. Kaya sinasabing, mas sulit magpabakuna kaysa magkasakit, kaysa magka-myocarditis, kaysa magka-MIS-C, o kaysa mamatay.
Buti na lang hindi mo sinabing bakit hindi dahil kay Dr. Ellen o Dr. Mark ang pagka-fracture. Buti na lang.
nga. Nag-serve lang ng refreshment, nadapa pa tuloy, di pa kawawa naman.
Oo nga, So, ay nako, it's such a, in fact, there's a whole book on causality and how we go through statistics to be able to prove causality and that. Perhaps last few questions. They're very interested in myocarditis. First, how long do you have to observe so maybe perhaps we go through the data, how when myocarditis occurs, when does it occur, and second, and what are the symptoms that they watch out for in myocarditis?
Okay. The symptoms are, let me just draw slides so it's easier to understand. The symptoms are typically quite mild, and you have mild chest pain or pressure or discomfort, and then you can have fast heartbeat, you can have a little pain on breathing, and they typically will happen within 1 to 2 weeks of receiving the vaccine. Kaya nga ngayon, the recommendation is that you abstain from strenuous physical activity within that time frame, just so that you don't get confused as to what could be the possible source of the symptoms. Kasi these symptoms can also show up in myocarditis from any kind of source, no? Because myocarditis is actually something that is that can be observed in kids. Hindi siya necessarily, it's not an unknown event for children. So are you seeing the slide again? The World Health Organization slide?
Dr. Anna, it's blank.
Oh, I'm
Black.
sorry.
So you have to unshare and then share again.
Yeah. Let me see. There. There. Is that showing up?
Yes,
So
yes.
this is the
Yes.
part of the infographic that talks about the symptoms. It's a chest pain, no, that can be quite mild, parang pwedeng pressure lang, and then pwedeng palpitations, pwedeng shortness of breath, a little being out of breath even with your regular activities. So again, as I mentioned, because this can be caused by other viruses, this can be caused by strenuous activity. Those are some of the things that we're asking people to abstain from after vaccination so that we don't get confused and misattribute it to some other cause.
I think there's a follow-up here, no? So just in case that there are these symptoms displayed by the child, no, they found these symptoms, what should parents immediately do?
Well, of course, we need to confirm whether this is actually myocarditis or not, because there's so many other possible explanations for the symptoms being felt. The doctor will have to do some tests to make sure that this is indeed related to the heart. And then typically, the recommendation is just providing rest and support for the heart function if necessary. And in most cases, spontaneous recovery has been reported.
Okay. So that means, sorry for my ignorance. So ibig sabihin, if we found these symptoms, hindi siya yung immediate na there's something bad that will happen. We can actually call our doctor, bring them to the hospital for checking maybe.
Yes.
There's time.
Yes, definitely. Because these symptoms are quite mild, and in fact, no, they've escaped notice by many people. Nagkaroon lang kasi ng reporting, kaya nagkakaroon ngayon ng heightened awareness. And of course, that's always good. No? We want to be very, very careful for whatever vaccines we give. And so this is now being reported and captured by the system.
Okay. So I think that we can end our very fruitful and very very informative Q&A here, Doctora. Thank you very much for this very nice presentation and very clear explanation to all our questions. Thank you, Dr. Mark and Dr. Ellen, for co-moderating with me. And now let us call on our SJCSAA Secretary, our LM Parents Auxiliary Group President, Ms. Jehan Lee, to present the certificates of appreciation.
Good afternoon, Sir Kenneth. Can you share the certificate of appreciation? Thank you. St. Jude Catholic School Alumni Association, St. Jude Catholic School Parents Auxiliary Group, St. Jude Catholic School award the certificate of appreciation to Dr. Annalisa Ong for sharing her expertise to the SJCS community as speaker in the webinar, COVID-19 Vaccines, Cha-Cha-Cha, Should Children Be Vaccinated? Via Zoom Live and YouTube, given this 14th day of November in the year of the Lord, 2021. Signed, Reverend Father Roland Aquino, SVD MPA, School Director of St. Jude Catholic School, Mr. Johnny C., President, SJCS Alumni Association, Mrs. Rachel Garcia, President, High School Parents Auxiliary Group, Jehan Vanessa Lee, President, Elementary Parents Auxiliary Group, Audrey Miet Season, President, Early Childhood Department Parents Auxiliary Group. Thank you.
Thank you, Jehan. And now may I request everyone to please turn on their webcams. Let's have a group photo. So may I request everyone in the Zoom room to please switch on your webcams for our group photo. 请各位在直播间的观众们呢，打开你们的摄像头，让我们一起合影留念。Okay, ready? Smile. 1, 2, 3. And I think we're okay. Thank you very much. And for our closing remarks, may we call on the SJCSAA incoming president, Ms. Stella Malin Sia.
Hi, good evening. Thank you very much. Thank you everyone for joining us on this very, very informative seminar on children vaccine for COVID-19. Special thanks to Dr. Anna Ong-Lim, our speaker. Thank you to the panelists, Dr. Ellen, our moderator, Dr. Mark Ko, and Shirley. Thank you also for Dr. Roslyn Ko Di Chow for conceptualizing and coordinating this speaking engagement. Thank you very much, St. Jude Catholic School, Father Aquino, Father King, Father Lee, for always extending your support to the Alumni Association and the SJCS PAG. Thank you, Mr. Kenneth and Sir Don, for your technical support. COVID-19 has really disrupted our lives. Vaccine has always been an issue, not only for kids, but also for adults. And, there are just so many questions, and it's really not an easy decision to make. But I hope you bring home the information shared by Dr. Anna this afternoon, which will help you make your informed decisions. COVID aside, the AA and PAG should continue to arrange health and well-being forums for the SJCS community. We would really love to hear everyone's suggestion, comments, and we'll try to do our best to arrange and improve on them. Once again, thank you very much and take care, everyone. Thank you.
Thank you, Malin.
Thank you.
And maybe request Dr. Anna to say a few words before we close this session. A few reminders, maybe.
Thank you, Shirley. And thank you once again to the St. Jude Catholic School community for the kind invitation to speak to all of you. I think I just like to remind everybody that the virus is still here. And in all of the excitement that we've had about community restrictions being loosened and kids finally being allowed to go out, let's not let our guards down, and continue to practice the minimum public health standards that have protected us all these months, Parang let's not allow ourselves to be beaten by this virus, because for sure we're we're smarter than it is, and if we understand how the virus behaves, then we should be able to put up adequate protection. And now that vaccines are here, it's an extra layer that we should all take advantage of. I hope for those age groups that are already qualified to be vaccinated, we should really take advantage. And especially, if there are still people in the community belonging to the A2 and A3 who haven't been vaccinated yet, let me please ask you as a special favor, wag nang mag-intay pa, magpabakuna na, because this will really be the key to your protection. Even before thinking about getting the kids vaccinated, I think it's only fair for adults not to be the first ones in line. Kasi tayo naman ang at risk at sila naman ay nahahawa lang. Hindi naman yata tama to ask them to be vaccinated when we ourselves are not willing. Thank you.
Thank you again, Dr. Ana. And now may we call on Father Peter Mayley to say a few words and then lead us in the closing prayer.
Yes, thank you, Shirley. Hello, everyone. A pleasant evening to you all. Yes. First of all, I would like to thank Dr. Anna Lisa Ong-Lim for the very informative talk. And you give us the background of should our kids be vaccinated. Very nice topic. And also thank our SGCS incumbent President Johnny Shi and your team for hosting this very timely and healthy talk. It is good for our parents and also for school administrators for the decision making in line with the deaf and requirements. Thank our alumni and also parents and students for participating in this webinar. It's very relevant and informative for all of us. And let me also take this opportunity to thank our incumbent Mr. Johnny Shi, our SDCS Alumni Association President, and your team for past 2 years, and the service for St. Jude Catholic School and our alumni for your contribution. We, in behalf of St. Jude Catholic School, thank you for the service and the contribution. I know even you're not your outgoing president, but I think you and your team still support the coming and incoming president and Mrs. Stella Malaysia. And we congratulations to our incoming president and your new team. St. Jude Catholic School is looking forward to more cooperation and also your innovation. So we hope see you soon. So please stay safe and keep healthy. And God bless you. And just a while ago, Dr. Anna said the virus still is here. So just stay safe, keep healthy, take care of yourselves. So God bless you all. So let us put ourselves in the presence of God. So dear Lord, we thank you for this wonderful and meaningful afternoon. We know you are the Almighty God. You control everything. And we know you provide the information and the wisdom and the knowledge through the doctors' talk, and also through their hands, you heal us. And through the vaccine, you cure us. And we ask you to protect us, to keep us healthy. Let us continue to glorify your name in our lives. So may you continue to guide us and give us hope and give us courage to live and to look forward to our new life and to back the normal life, continue to do our mission on earth. So we ask this through Christ, our Lord. Amen. St. Jude Deus, pray for us.
Pray for us.
We together pray, glory be to the Father, and to the Son, to the Holy
and to the Holy
Spirit,
Spirit. As
as
it was in the beginning,
is now,
is
ever
now,
shall
and ever
be,
shall be, world
word
without end.
end. Amen.
Amen.
God bless you all. Stay safe and healthy. Thank you.
Thank you very much, Father Peter.
Thank you, Father Peter Lee, Sisyelishan Fu. Our webinar, Health Talk for today, has ended. And I hope everyone learned a lot, just like me, from this very informative and very nice presentation from our resource person, Dr. Annalisa Ong-Lim. And I would like to also thank my co-host, Dr. Mark Ko, and my co-moderator, Dr. Ellen Tanku, and of course, Dr. Rosaline Kodichao for organizing this. I hope everyone enjoyed this session. See you again in our next Health Talk series. Bye.
Bye-bye.